si tira su bevendo come se fosse.
Ragazzi, are you ready for the next episode? We are coming soon. Ben trovati, welcome.
So now, can you explain at least why you start earlier and earlier and earlier and earlier every week earlier? Why?
Because we try to understand how to finish not in time, but at least not at 8:45
Well,
like the last time.
the previous effort was not very successful. Let me.
Yeah. We are
Hello, my
perfectly
friends. Hello,
Hi,
how are
guys.
you?
Hello.
How are you?
Hello, hello. Hello,
Everything.
Serbia, Argentina, Bulgaria, Costa Rica, Turkey, Nigeria, Germany, Brazil, Poland, Brazil, Hungary, Egypt. Continue. Go. Slovenia, Romania.
Yeah.
All over the globe.
Yes, perfect. Lithuania. Wonderful. Sebbi, what kind of question of the week we have tonight? We are going to talk about something I suppose we never talked about, maybe just once. Do you use your
What's that?
dermoscopy for hair diseases? Come on. Sebbi, where did you find this beautiful professional picture of Emilio?
This is
Emilio sent us.
first of all,
Ah.
this is off season.
It was on his application for full professor.
Yes.
See. Wonderful. Yes, by far, 90%. Wow. Well, sometimes voted just a few. And no, we have to convince two people today. Nisa, it's up to you to convince two people to use dermoscopy for trichoscopy. What? Nisa, we
You're
cannot
muted.
hear you.
Yeah, I hope I can manage to present this topic to the audience because I'm not very experienced as well on trichoscopy. So we
Yes,
will learn together.
But
we
do
will
you
do
use
it
it?
together. We will do it together.
Yeah, yeah.
Okay, Giuseppe, do
Okay.
you use it?
Yes, I use it. I use it. Of course, let's say, well, I will tell you. I will tell you with my cases when I find it particularly useful. Yeah.
Emilius,
What?
if you use trichoscopy.
If I use, okay.
Especially for your for,
Basically, this episode should be run exclusively by me and Sebastiano.
Well, I'm getting there. I'm getting there.
Well, come on.
it's a long way to go for you, Costas.
Very slowly, very slowly. Yes, of course, come on. Of course I use it. Come on. Yes, definitely yes is the answer. Sure.
Yeah. Wonderful, wonderful. So Nisa, we are curious to hear you.
Yeah, okay. Let's share the screen. We are going to talk about, again, our favorite journal, Dermatology, Practical and Conceptual. And this review performed by the International Dermoscopy Society on imaging in skin of color test group. And they systematically analyzed dermatoscopic features, especially in skin of color patients, skin color 4, 5, and 6. And for me, it's not so different, just some pigment difference, maybe reticular network, honeycomb, pigment network are much more common in skin of color, but the rest are very similar with fair skin type patients. And in this review, they retrospectively analyze the dermatoscopic features and they look for a lot of publications, but at the end, 60 articles with full text admitted to the study. And let's first start with non-cicatricial alopecias and start with alopecia areata, which is the most common form. And as all we know, the yellow dots, black dots, short vellus hairs, broken hairs, and micro exclamation mark hairs were the most common features in alopecia areata in dark skin types. And the diagnostic sensitivity of yellow dots were found to be the almost around 90%. And when we combine it with short vellus hairs, the sensitivity increased to 97%, and diagnostic value of exclamation mark hairs was higher when detected along with the other findings of alopecia areata. And here's a patient. Actually, this is my patient. You can see some black dots, exclamation mark hairs again.
Show them, Lisa, show them. Show the
Can
exclamation.
you see my arrow?
Yes.
Can you see my arrow? Yeah. You can see the black dots, which is a very common feature of alopecia areata. And you can see here exclamation mark hairs. The proximal part is thinner and the distal part is thicker. You can see, and they have different length here. And here you can see some yellow dots, which is a very common feature of alopecia areata. And here we see pigtail hairs. And this is generally related to spontaneous remission or answer to the therapy. So this is a good sign. When we see pigtail hairs, it's spontaneous remission or good response to therapy. And here are some activity markers. If we see yellow dots and short vellus hairs, this shows the stability of the disease. And if there are black dots, broken hairs, codability hairs, as far as I understand, these codability hairs are the longer version of exclamation mark hairs. Here you can see the proximal part is thinner and distal part is thicker, but this is much more longer than exclamation mark hairs, and they call this codability hairs. Is it right? Do you agree?
Yeah, yeah.
Yeah, I think they also call them tapered. Tapered.
Yeah, tapered.
By the way,
I think they are the same.
May I comment something? This
Yeah, sure.
the alphabet of trichoscopy
It's very analytic, right?
is full of metaphoric terms, but
Yeah,
nobody
yeah.
complains about it. I mean, it's so metaphoric that sometimes, I mean, you have to think what we're speaking about. You know,
Yeah,
Yeah,
pigtail.
yeah,
yeah.
yeah. And I looked for the dictionary, what's codability hair.
Yeah.
Finally, I understand it. Okay. And when coming to yellow dots again, the higher density of yellow dots would be related to the disease severity. And the highest mean number per field in alopecia universalis, and the lowest density being detected in localized patchy alopecia areata. And trichoscopic chains following intralesional steroid therapy are, if there is the presence of exclamation mark hairs, was the first feature to disappear after 4 weeks of treatment, followed by broken hairs, black dots, and yellow dots. And at 4 weeks of the treatment, the appearance of pigtail hairs and short vellus hairs, and also pigmented hairs, show the good response to therapy. And now let's go to androgenetic alopecia, female pattern hair loss type.
Any idea?
Hair diameter.
I interrupt you. Any idea why the number of yellow dots is associated to the severity of the disease? So yellow dots result from what? From sebum.
They're
follicle.
sebum, empty follicles and filled with sebum.
Sebum.
Maybe if it's expensive.
Yeah. So the point is that when there is no hair at all, then yellow dots are more frequently seen. You know, so it's just a matter of the amount of hair you see. If there is nothing, then yellow dots are more.
No, I knew that the presence of yellow dots is a marker of a stable, quite long-standing disease, not very active. But I didn't remember that the quantity of yellow dots is related to the disease severity. Anyhow.
Yeah.
Good.
And when coming to androgenetic alopecia, female pattern hair loss type, hair diameter diversity is a much more common feature of this pattern. And then we can also see short vellus hairs, brown peripellar sign, single hair follicular units, thin hairs, and yellow dots. Let's have a look at the trichoscopic features of androgenetic alopecia, female pattern. And here, this is the first photo is a normal hair. And the second photo, you can see brown peripellar sign. This is very characteristic for this pattern, as you can see here. And also, hair shaft thickness is different. This is thinner and this is thicker. This is very characteristic. And also, in skin of color, honeycomb pigmentation is a common feature, as well as pinpoint white dots, and also focal atresia. Here you can see atresia areas, and peripellar white hypopigmentation is also a common feature. So peripellar brown pigmentation and peripellar white halo, also very common feature. Here, another photo, you can see white dots, and there's also a sign. There's brown pigmentation around these white dots. It's also a common feature of female androgenetic alopecia, female pattern. Here you can see brown halo around the perifollicular area, which is a characteristic finding. And when coming to tinea capitis, this is my favorite. The most
Maybe Lisa,
prevalent finding.
maybe Lisa, before we go, wait that we take a couple of questions. A question is concerning areata. Do we see the same patterns in children, in pediatrics? I would say
Yeah, same.
yes.
Yes.
More or less the same.
Same.
There is also a comment by Sheen suggesting that caudability hairs seem to be the ones with the proximal kink in the hair shaft due to the hair shaft thinning. I'm not so sure, to be honest.
I think lymphocytic activity is much severe here. So
Yeah.
this part is thinner.
Again, there is a question: what is caudability hair?
This
Yeah.
is caudability hair.
I love
Thinner
it.
part and thicker part from the distal part, and different from exclamation mark here.
Just because it's longer.
These hair are longer.
It's a long exclamation mark here.
Yes,
Yeah.
it's an exaggeration of the exclamation here.
Yeah.
Yeah. Are yellow dots a frequent finding of alopecia areata in children?
Yeah.
Really?
Yes.
Well, children usually do not produce too much sebum.
Yeah, depends on the age.
Yeah.
This is a child,
Okay.
80 years old. Yeah.
8. Huh.
Mhm.
Interesting.
Wonderful. Somebody wants to know my hairdresser name. Yeah.
He has nothing to do, right? Very, very lazy guy.
Go.
And this is tinea capitis, coma hairs, broken hairs, perifollicular white scales, corkscrew hairs, lots of metaphoric terminology here. And less frequent findings are zigzag hairs, Morse code hairs, E hairs, pustules, and white dots. Let's have a look at the dermatoscopic features.
Very featureful, Tina.
Oh my God.
Yeah. And there are 3 variants: endotrix variant, gray patch, and black dot tinea capitis. In endotrix variant, we have corkscrew hairs, comma hairs, and zigzag hairs. And in gray patch tinea capitis, we have perifollicular scales and black dots, erythema and telangiectasia, and hemorrhages of carrion. And in black dot tinea capitis, we have comma hairs, black dots, and perifollicular scaling. And here you can see comma hairs.
Comma, yeah.
Yeah. It's a very characteristic finding. And we can also use dermatoscopy in post-treatment monitoring. And disappearance of dystrophic hairs was reported as a marker of therapeutic success, and persistence of perifollicular scaling despite negative results of mycological culture. And here we have trichotillomania. Again, we have very characteristic dermatoscopic findings: broken hairs of variable length, trichopitalizes, black dots, hook hairs, peripillar hemorrhages, V sign, and flame hairs are very characteristic findings of trichotillomania. Here we have V sign and flame hairs, and hairs have different lengths here. We have here coiled hairs, and
is amazing.
yeah, this is the response to a pulling force. And again, broken hair of different lengths. And we have trichopitalizes here, black dots. And less frequent features, tulip hairs. Tulip hairs means the distal portion is darker than the proximal part. It's a very common feature of trichotillomania. And we have also hair dusts due to the pulling of the hair. And another tulip sign here.
Which looks like an exclamation mark, by the way.
That. With this black part right at the edge of the hair is a sign. And now let's move to scatricial alopecia and centrifugal scatricial alopecia.
Wait a
This
moment.
pattern,
Wait a moment.
Go ahead.
Questions again. Before we go to cicatricial alopecias, are yellow dots also present in androgenetic alopecia? Yes, they might be
Yes.
present. Do you find exclamation mark hair in other hair disease than alopecia areata? Are they pathognomonic for alopecia areata? Well, yes, they are considered quite pathognomonic for alopecia areata. Yeah.
Yeah. It's very rare in the other alopecias, non-scatricial
Yes.
alopecias. Yeah.
Yeah. And we are good to go.
Yeah. And in centrifugal scatricial alopecia, honeycomb pigmentation is very common, 100% specific to this alopecia. And also perifollicular white halo, as observed here, pinpoint white dots, and scatricial white patches are very characteristic findings. And when compared to other scarring alopecias, perifollicular white halo turn out to be the most accurate finding with a specificity of 100%. Here we have perifollicular white areas and honeycomb pigmentation and pinpoint white dots. Again, it's very characteristic. Discoid lupus erythematosus is also very easy to diagnose on the scalp because we have follicular plaques, white scarring patches, and perifollicular white halos. And these follicular plaques are very characteristic. And also we have vessels, and the vessel morphology is much more common when compared to other scatricial alopecias. And these vessels can be branched vessels, serpentine vessels, as observed here. And other main features included red dots and brown dots. For example, the left part is a lichen planopilaris, and the right part is discoid lupus erythematosus. We can easily differentiate these two entities because of these follicular plaques, scales, and white and pink patches. Again, follicular plaques are very prominent, and we have here also vellus hairs and white patches, which show the scatricial feature of the disease.
Nisa, in this picture, it's perfect. If you go back for a moment,
Yeah.
If you go back one more back. Okay, so on the right we see very nice follicular plaques, and so everything is okay. I mean, the lesion on the left is not so easy, by the way. I mean, to my estimation, because I mean, there is also a kind of follicular pluggings, or so it's not so.
Not so easy, maybe.
Not so
Yeah.
easy. Yeah.
That's a lichen planopilaris on the left.
Yes.
Mhm.
Yeah, I agree. I would also go for lupus more.
Very difficult, yes. Because there's also the post-inflammatory hyperpigmentation, so you would expect to be a more heavily inflammatory process there.
Okay.
Yeah. And here we observe these telangiectasia vessels, which is a very common feature of discoid lupus erythematosus, along with follicular plaques. Again, the vessel morphology and white patches and some follicular plaques. And when we observe white patches, we understand that this is not an active phase, but when we observe dotted vessels, we understand that the disease has an indicator of an active disease.
Yeah. Mm-hmm.
And let's go to lichen
There is
planopilaris.
a request to show again pinpoint.
Yeah.
Pinpoint
Vessels. In lichen planopilaris,
no, they ask
the
you
most
to show them again, Nisa.
Over there.
Okay. And when we go to lichen planopilaris, perifollicular scales, gray dots, and white patches are characteristic finding of lichen planopilaris, but also in skin of color patients, blue-gray dots in a targetoid pattern is a very specific finding. For example, let's look for this sign. You see the hair follicle. We have a targetoid pattern of gray dots, and we observe this pattern in lichen planopilaris in skin of color. And we have also some white dots and perifollicular scales, which is a very characteristic finding for lichen planopilaris. And when we move to frontal fibrosing alopecia, which is also a type of lichen planopilaris, perifollicular scale is again a very characteristic finding. And let's go to dissecting cellulitis of the scalp. The lack of follicular openings, scapular white patches, again black dots, crusts, perifollicular scales, yellow dots, elongated linear vessels, and interfollicular scaling are the most common features of dissecting cellulitis of the scalp. But also, there's a very characteristic finding, which is not very common, but when we see this feature, and this feature is called in metaphoric language as 3D yellow dots, as observed here, and some yellow patches, this is a very characteristic finding for dissecting cellulitis of the scalp. And when we go to folliculitis decalvans, loss of follicular openings, scale, and follicular pustules and hair tufting is a very prominent feature. Here you can see hair tufting, pustules, and yellow scales in folliculitis decalvans. Pustules were found to be a marker of active disease, whereas hair tufting turned out to be an indicator of disease severity. Now, I have some questions to you, after all.
Nice.
So, what's the diagnosis here?
Alopecia areata.
Perfect, because we have here
Exclamation mark.
exclamation mark hairs. Yeah. And what's this?
Androgenetic.
Genetic.
Androgenetic alopecia, female pattern loss, because we have hair diameter diversity here, right?
Yeah.
Some thick and thin hairs. And what's this? Any idea?
Huh.
See, the gray circle was in line with androgenetic alopecia again.
Yeah, this is another androgenetic alopecia. This
Yeah.
time we have
Skin of color.
multiple.
Yeah.
Yeah, this
Skin
is
of
the
color,
advanced
because
form.
This is
early.
You never see this in Caucasian people, but
Yeah.
skin of color you can see
In
this.
skin of color, yeah. And in skin of color, here the main major clue was brown pigmentation around follicular ostia and brown peripillar sign. And this is an advanced androgenetic alopecia. This is easy.
Tinea.
Tinea.
Yeah,
From
tinea. And what's the pattern? What are those structures? How do we call them?
corkscrew.
Corkscrew.
Corkscrew. And also some comma.
Should be
Corkscrew and
trichophytic.
comma.
Should
Yeah.
be trichophytic, exactly.
Perfect. And what's that? I didn't mention this during my
This is
presentation.
Trichomycosis palmellina.
Looks like a
Ah,
good differential. This is
What?
a sort of traction alopecia. Because
traction.
in traction alopecia, we have white peripillar casts and thin vellus hairs. And this is also a very characteristic finding for traction alopecia. And what's this?
Tinea.
Tinea. Because what are those structures?
Zigzag or yeah.
Broken
Morse code, yeah.
Morse code hairs, perfect. And perifollicular scales. And what's this?
Trichotillome.
Yeah.
Perfect. This is trichotillomania. We have flame hairs. And the hairs have different lengths, broken hairs. Perfect. And now let's go to scatitial alopecias. What's this?
Lichen.
Planopilaris.
No.
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 Just concentrate on perifollicular white.
No, the answer is in the chat. CCCCA.
CCCA.
Yeah, perfect. This is centrifugal scatitial alopecia, and this white perifollicular hypopigmentation is very characteristic. And also we have some white pinpoint dots. And what's this?
Melanoma.
Not a melanoma.
No, it's not.
They are pigmented follicular plaques,
Yeah.
white patches of alopecia.
Yeah, lupus.
And this is discoid lupus erythematosus because
Not
of
so-
this follicular
so
plaques.
Not so erythematosus in this case.
Yeah, it's a skin of color patient, so
Pigmentosus,
the things
pigmentosus.
are
Discoid lupus
hyperpigmented.
pigmentosus. Yeah.
Yes.
Yeah, discoid lupus pigmentosus. This is nice. And what's this? These structures are pathognomic.
Folliculitis, the Calvans. No? No.
Mm,
No.
No,
Dissecting.
dissecting cellulitis because of these 3D structures and yellow patches, alopecic areas.
How many cases of dissecting cellulitis of the scalp did you see in your life? In my estimation, even not one. So
I personally
why
have
should
seen
we
0.
study a disease which we never see?
Probably I've seen one or two, but I've never seen that 3D structures.
Yeah.
But they say that it's pathognomic, nothing to do.
Okay.
Okay, easy one.
Lichen planopilaris.
We have perifollicular scales. So this is it's sort of lichen planopilaris, and this is on the frontal part, so
Fibrosis.
frontal fibrosing alopecia. And what's that?
Folliculitis.
Yellow crusting and tufted hairs. So this is
The Calvans.
The Calvans.
folliculitis decalvans, perfect. And this is the late phase of folliculitis decalvans. You can see the tufted hair follicles and white patches of scatitial alopecia. And what's this?
Lichen planopilaris.
LPP.
Lichen planopilaris, yeah, perifollicular scales and targetoid structures, gray structures around the hair follicle. And this is the last case. What's this?
Monolatrix.
Perfect. These are braided hair with equidistant nodes and internodes, and this is a characteristic finding of monolatrix. That's it.
Fantastic.
Wow,
Fantastic.
wonderful.
Fantastic.
Brava.
We have a
Wonderful,
number of questions. What is the meaning of perifollicular gray color in androgenetic alopecia?
Who knows?
Yes, I mean, why do we see perifollicular gray in androgenetic alopecia? I don't know. Nisa?
But they are skin of color patients. Maybe there's pigment incontinence. I don't know the reason. Probably it's a sort of pigment incontinence.
Uh-huh. Does perifollicular halo indicate atrophy? Well, perifollicular white halo indicates fibrosis surrounding the follicle, which is the case in lichen planopilaris. But perifollicular...
And here,
yeah.
And also androgenetic alopecia, female pattern. Here you can see perifollicular white areas.
Wonderful.
Coming back to chronic androgenetic alopecia in children, I understood that yellow dots are indeed scarcely evident due to the poorly developed sebaceous glands. Is that correct? Well, depends on the age. Of course, after a certain age, there are sebaceous glands, and of course, there is sebum. Okay, no, the others were answers. Peripillar sign, says Yazid, is probably a consequence of perifollicular inflammation. Could be, but why does this occur in androgenetic alopecia? I don't know. And again, peripillar size shows perifollicular lymphocytic inflammation, says Neki. How do we see dissecting cellulitis? There is a comment in the chat that dissecting cellulitis, JP, that you said it's rare, appears to be very common in the African American community.
Oh.
So, yeah.
Okay.
Uh,
Then perfect. I understand.
Yeah. Then there is a question about erosive pustular dermatosis. We will show you many cases in other occasions because we have really good collection. And I think that we got most of the questions.
Emilio, show your cases.
No, leave my cases for the end, Jeff, so that I can.
Okay. So I go with mine.
Yeah.
Okay, go with mine. I will show you a few cases which I find interesting. Let me show you. Okay. So this is the clinical
Black dots.
of a post-puberal young guy. Okay, and this is what you can see dermoscopically. Nisa, tinea. Yeah, exactly. Exactly. And you know what? Yes, exactly. So the point is that, of course, we cannot perform a diagnosis of tinea only based on the clinical and dermoscopic picture. But what should we do? What should we do?
Fungal culture.
KOH microscopic examination. It's very easy. So that's what I always say to the young colleagues. Please buy a regular conventional microscope to do your own microscopic mycologic tests, because this is very easy. It's very fast. You just do a scraping and then you see these beautiful findings, which are the spores, but particularly the hyphen probably, no, yeah, which are interrupted, segmental, and these are, I mean, now you are 100% sure that this is a tinea, and you can perform a long-standing treatment, systemic treatment, because you have to use griseofulvin, I don't know, for a couple of months at least. So it's better to confirm by the microscopic examination. Another case which is much more easy because we are in the range of the classical tinea capitis. Do you know why, by the way, tinea capitis is more frequent in children than in adults? Do you know that?
No.
Yeah.
Yes, it's because of the sebum.
Sebum.
Yeah. Sebum, exactly. So sebum is protective against Microsporum canis, okay, which is by far the most common dermatophyte involved in tinea capitis. And so since children do not produce too much sebum, they are more exposed to the infection, okay? And here you see...
But there's a controversy. For example, in infantile periods, seborrheic dermatitis is very common. So they have sebum in the infantile period.
Newborns, but in newborns.
Yeah, newborns.
Which are getting the hormones by the mother by breastfeeding, you know. So, but once you leave your newborn moment,
infantile period,
breastfeeded anymore, then you don't produce sebum anymore.
Is it the same for scabies? Is sebum?
Exactly. Sebum is very protective. In fact, that's the reason why face and sebaceous areas are not too much involved by the scabies mite. Yeah.
Fungostatic, as far as I know.
Exactly. Exactly. So here you see the beautiful Morse code sign So these hairs, which are, let's say, not pigmented anymore in some parts of the hair shaft. Okay. Okay, another case. That's the clinical. And that's,
Discoid. Easy. Daily.
you say discoid lupus.
Yeah.
Lichen planopilaris?
No,
you don't like?
No, I don't like it. Look first at the clinical picture. This is multiple spots of erythematous alopecia areas. And here, in my view, what is stronger is the presence of this tuft.
Follicular plaques?
The calvans,
Tuft?
you mean?
Yes, the calvans.
You mean
this is
Yeah, but
folliculitis calvans. Yeah.
yeah.
Look
Actually,
at
it looks like a combination of lichen planopilaris and the discoid lupus erythematosus. We have follicular plaques, we have perifollicular scale.
You have many signs. You have including perifollicular hyperkeratosis, but I mean, I don't expect to find so many tufted hair in lichen planus. So, in my view, in this case, tufted hair is the most important clue.
By the way, since you speak about the calvans, there is a question: how do you treat it?
Exactly. That's the point I wanted to make. And in my view, the treatment, the first line treatment by far, which is the most useful one, is isotretinoin. Okay? Isotretinoin is going pretty well.
By the way, in the question in the Q&A, the colleague says that he tried doxycycline, he also tried isotretinoin, doesn't get better. What should I do next?
Exactly. Do isotretinoin. You will see.
No, done also isotretinoin.
Done also.
Adalimumab.
Then
adalimumab.
TNF alpha inhibitors.
And the TNF.
Of course, then you can try whatever anti-inflammatory drug, but usually with isotretinoin, I cannot recall one case which did not respond to isotretinoin. Of course, the problem is the long. This is a chronic disease. Yeah. So once you stop the treatment, then the disease will come back. So you have to find a way to prolong as much as possible with dose tapering the use of isotretinoin. So usually I start with low dose every day, 20 milligrams per day, and then I try to find the lowest dosage which is able to maintain the result. Okay, so for example, every other day, 10 milligrams every other day, or 10 milligrams every 3 days. So it depends from the response.
There is also a comment about dapsone, which makes sense because it's a neutrophilic inflammation in the calvans, but I don't know what kind of data we have on the efficacy of dapsone for the calvans, but it makes sense.
Actually, I want to say that I had a case of the calvans that was resistant to doxycycline, then isotretinoin, and with dapsone it went great, and still.
Oh, really?
Right. Yeah, because it's neutrophilic infiltrate, right? So any anti-neutrophil will work. But
it's difficult to get all the questions. Going back to tinea, do you base your decision to stop treatment on a negative fungal culture, or just the immediate examination is enough, or the clinical examination?
We have to respond after a negative microscopic examination at least, but in the practice we use the clinical examination. If there is nothing, if the hair coming back and there is no scaling anymore, no signs anymore, then we can stop.
I would say that clinical plus dermoscopy, of course, but I would say, as I commented when Nisa was presenting, tinea is featureful in general. We see a lot of things in tinea. Therefore, when everything disappears, it appears to be quite safe to say that it's over. There is a comment that Clinicept Plus, which is a hypochlorous solution that kills bacteria, is also could be used for decalvans.
Mhm.
Okay.
Concerning the dosage of isotretinoin, I do as a rule, not only in folliculitis decalvans, but also in severe acne, just low dose treatment. I start with 10 to 20 milligrams, and maybe I go to 30 milligrams. Very rarely I go to 40 milligrams. And they use the lip scaling as a rule to guide my decision. If it's enough, then it's okay. If it's not enough, then I increase by 10 milligrams.
Yeah.
Okay, so we have no time anymore. This is a more heavy case of follicular decalvans.
Yeah.
Decalvans. And here you see a beautiful case of lichen planopilaris, if you agree.
Absolutely.
And we finish with this one. You have to tell me what you think about it. Do you see this?
Sarcoidosis.
Yeah, exactly. So
Yeah,
could be sarcoidosis. It could be sarcoidosis
bleeding.
because of the orange color, but also foreign body reaction is a differential. So we have to make a diagnosis, a biopsy to make the diagnosis. In this particular case, it was diagnosed histologically as a foreign body reaction by the tattoo color, but of course also the tattoo color can induce sarcoidosis, especially on the eyebrows. Wonderful.
Wonderful.
Beautiful.
Before we proceed, do we have to show something, Sebi?
Yes. Yes, Sebby, go.
Guys, I think I'm losing hair. Just kidding. I'm not even gonna lose hair. Okay, look at this bush. People, it's time to show you the TRICHOSCOPY DX, an incredible smart software that allows you to analyze the scalp, to analyze the hair in a very quick and comfortable way for patient. You don't need to clip hair, you don't need to shave the hair. You just ask your patient to have a seat. You take the one and only Photo Finder Medicam 1000 and take a brilliant dermoscopic picture of the scalp. Trichoscopy, that's how it's called. And then you just run the software and look at this. Analysis, automated, in front of your patient. It changes your communication. It allows the patient to be involved. And you can print a report immediately with all the relevant parameters, hair density, the thickness of hair, the cumulative thickness, important information for your PRP treatment, for your mesotherapy. People, you gotta try that, okay? Try it now.
I love Moha's bow tie. It was wood with musical notes on it.
Yes, yes, yes.
Yes.
Wonderful, wonderful, wonderful.
Konstantinos, go.
Okay, I will be very short so that we don't run late again.
Oh, we will, but yeah.
Not extreme. Not
This is a
extreme.
very important episode. Trichoscopy.
Absolutely. But last week we managed to do it 2 hours. Let's get to 1.5 this time.
Yeah.
So, a young individual in her teens presents with this balding site on the top of the hair, been there for the past 3-4 months, and this is the dermoscopy. What would you say that this? Sebi?
There are some pigtail hairs, so
Okay, the options are lichen planopilaris, trichotillomania, frontal fibrosing alopecia, and fungal infection. Okay.
how old is the patient, Konstantinos?
14.
14, okay. Tinea.
Trichotillo is the winner.
Trichotilo is the winner, and it was indeed trichotillomania. You can see the different size of the hair, a lot with some dots here. And the patient, after discussing in length, had problems with her mom, etc., and was consulting with a. I sent her to consult with a child psychologist. Next one. This is the clinical, and this is the dermoscopy. Do we see any alopecia here? Not so much.
A SEP-K or a BCC?
Is this alopecia areata? Alopecia basaliata?
Basaliata.
Let's see what people think. Lichen planopilaris, really? Ah, it's basaliata. It's a basal cell carcinoma.
It's a cell carcinoma, yeah.
See how much we are influenced by the frame. I mean, now that we are speaking about alopecias.
Yes, but that's why I put two oncology cases of this one, because
Yes.
of course they do come up in here. And this is the clinical, and this is dermoscopy on a 63-year-old lady. Take a close look at dermoscopy.
What's
And
that? Yeah. Sometimes, yeah.
Sometimes.
is this benign? Is this malignant? Or sometimes?
Yes. Yes.
And wonderful.
Malignant.
Is there something on nevus sebaceous?
Yes, nevus sebaceous.
Yes.
Yeah.
So it is malignant sometimes. So it's a combination of B and C.
Yeah.
Nice.
Combination of BCC and nevus sebaceous.
Yeah.
Ah, okay.
Wonderful. Fantastic.
Wonderful.
Giuseppe,
Beautiful case.
are you going to tell us something now or later?
After you.
After me.
Yes.
Okay, good. Fantastic. So I have a very nice collection of cases that were not prepared by me, but they were prepared, all of them, by Zoe. So they are very nice, let me tell you.
Thank
In
you,
fact,
Zoe.
In fact, I invited her to present them here. It would be much better, but she didn't want to.
Where is he?
Well, she's very close. I mean, if she changes her mind, she can still present them.
I can see him in the background.
Zoe.
In the background.
Zoe.
In the meanwhile, I start with the first one, which is this one, 30 years old male with this mild form of androgenetic alopecia. You agree?
Yeah.
Yeah. It's mild for the moment. No relevant medical history, blah, blah, blah. Complaints, however, that it got worse recently, diffuse hair loss. It happens sometimes in androgenetic alopecia. And then we take a look with our dermatoscope, and this is what we get. So do you agree that this is in line with androgenetic alopecia?
No. Alopecia areata.
There is something wrong. Alopecia areata. Exclamation. Look at the exclamation
mark hairs.
Exclamation mark hairs. Also broken hairs. Also black dots.
Okay. Now I have a question. Because I'm always struggling with this. This is the so-called alopecia areata incognita, right? Okay.
Yeah. Incognita is even worse than this.
I mean, we're tapering hair here also.
Okay. So the point is that the difference between androgenic alopecia and alopecia areata incognita is the development, is the course, the prognosis, because alopecia, androgenetic alopecia is a very slow motion process, while this will bring this poor guy to lose his hairs quite much faster than androgenetic alopecia.
Well, if it's active, if
it's active, of course. Yeah.
But there are, at least in this case, there are the trichoscopic signs are quite clear for that it's not a simple androgenetic alopecia.
Beautiful.
And here, if you magnify a little bit, you can see even better. Case number 2, 48-year-old male complains for pruritus and scaling since 2 months. And he was diagnosed as suffering from scalp psoriasis. started treatment with topical steroids and cyclosporine. And 1.5 month later comes back for the visit, and this is what we get. So is it in line with, first of all, with the diagnosis, and
No.
second, are we...
No,
This is not a
lichen
psoriasis.
planopilaris.
This is lichen planus or
Lichen planopilaris.
Yeah, most probably perifollicular scaling, quite evident, erythema.
Mhm.
The point is that the treatment was anyhow good because he was under cyclosporine.
yes, exactly.
Yeah.
But still it appears that, I mean, do we see signs of active disease here? I think yes. I mean,
Yes.
Yeah, erythema, scales.
erythema
Perifollicular.
and perifollicular scaling. So in any case, we are not satisfied with the treatment, and we have to modify the treatment a little bit. Case number 3, 35-year-old male complains for scalp pruritus, erythema, and scaling since 4 months. He was diagnosed with lichen planopilaris and received combination of cyclosporine and intralesional injections of steroids. Okay? Okay?
Okay.
Yeah.
Fantastic.
Okay.
Fantastic. So that's the clinical. You can see the patches, yeah? And that's dermoscopy. So are we satisfied with the result of the treatment? I mean, do we consider that we have maintained to control the activity and to reach a stabilization phase? Do we see signs of activity, or it appears inactive, in your opinion?
There are some perifollicular scales, but not very prominent. A little bit erythema.
Mhm.
So we can continue the treatment, I think.
Exactly. So I also think so. It's not as compared to the previous one. Here we don't see much of
Mhm.
signs of activity, which means that probably we have controlled the disease.
The
Of course,
disease.
the patches of alopecia are still there. Of course, the follicles are. We don't see the follicles because they have been replaced by fibrosis. That's reasonable for a lichen planopilaris, but we don't see signs of disease activity. Yeah, agree?
Agree.
Agree.
Fantastic. Case number 4. Alopecia areata since 5 years. Failure of intralesional steroids and DPCB to control the disease activity. Current treatment, cyclosporine 4 milligram per kilogram. That's
JAK
the
inhibitor. We need JAK inhibitor.
Aspetta un attimo. Cyclosporine. So this is under cyclosporine. Are we satisfied with the result? Do we see signs of disease activity?
Yes.
Yes, we do. So it's
Yes.
not only the clinical aspect, it's also dermoscopy, which suggests clearly that there is active disease. We see again exclamation mark hairs, recently broken hairs, black dots. Therefore, the disease is active. Fantastic. So we stop cyclosporine and we start baricitinib, which is JAK inhibitor with an indication for alopecia areata. And then 2 months under treatment with baricitinib. This is the clinical aspect. Of course, it's early, we have to say, to assess the response to baricitinib. But for the moment, we don't see something extremely optimistic from the clinical point of view. Of course, it's early, but
Yeah, but 2 months is not much. But
not much. It's not much. But let's see if dermoscopy can give us some more information so
It's better.
good. It's good.
Excellent.
We don't see any
Better.
signs of disease activity. The opposite, we see these very short regrowing
Red hairs,
hairs.
regrowing
Yeah,
hairs. Yeah.
exactly. So the difference between regrowing and exclamation mark is that they are both short, but they are the opposite. So exclamation mark are thin at the proximal part and thick at the distal part. The regrowing hairs are precisely the opposite. They are thick in the proximal part and thin in the upper part.
Yes.
And then, of course, 6 months after, so 4 months later, we also see the clinical response.
Super.
12 months later,
Perfect.
fantastic.
Excellent.
And
Fantastic.
then at 12 months, we decide to reduce the dose from 4 to 2, which of course is still debatable if you have to do it or not, but this is an option. You reduce the dosage in order to see if you can control the disease with a lower dose. And after reducing the dose, we have this clinical aspect. It's fine from a clinical point of view, but dermatoscopically, we can see the reappearance of signs of activity of the disease. You see the
Exclamation mark.
here,
Yeah.
which means that here the disease became again active. More cases by Zoe, 2 twin cases, 68 and 71, hair loss since 4.5 months, both of them. It's not the same patient, they are different patients, okay? So the one on the left, this is what you see.
Like
So,
DLE.
DLE.
The right. The right is DLE.
The right DLE. Like
The
a
right
black
DLE.
Right is DLE.
the left,
like a
LPPs.
the
Like
left.
implantus.
Okay, so this is the one on the left.
Left is lichen planopilaris.
Lichen planopilaris. Okay, so if you decide to biopsy, dermoscopy can guide you. For example, you select to biopsy here because it will be very probable that you get the correct diagnosis if, in fact, it's a lichen planopilaris, which in this case, this was the correct diagnosis. And look now, let's go now to the second one,
DLE.
Really.
DLE. Well, you say so because of the vessels, I guess.
Follicular plaques and vessels.
plugs a little bit.
And
Plaques
also,
and vessels.
also plugs, also plugs. So,
And we can say that the disease is active because of this vascularization.
yeah. And so here in the circle, you can see the biopsy site for this case. But in this case, it was something unique that you cannot ever imagine, and you cannot.
I know the case. I know the case.
So do you remember? Do you want to say?
It's breast cancer metastasis.
Wow.
Oh, really? Wow.
Unbelievable.
Wow.
Incredible. Incredible.
Of course, what you don't see here is the consistency of the lesion, which was quite strange. I mean, the lesion was quite firm on palpation, but it was really remarkable because it also affected somehow the hairs. It was not only the infiltration of the skin, which is reasonable. So breast cancer metastasis.
This is a great case, really.
When
Great
Zo-
case,
when-
and
when
mimicker
Zoe
of
was-
DLE.
When Zoe was telling me the case, and the most crazy thing is that it came into her differential. It was first in her differential. I was like, how? But amazing.
Yeah. An even better
Amazing
one.
case.
And let it be the last. So 32 years old, male, referred by rheumatologist because he was hospitalized with symptoms of intrahepatic cholestasis, mild fever, arthralgia, and muscle weakness. Anti-nuclear antibodies positive at a titer of 1 to 320, RF test positive, low titers of C3 and C4. Therefore, which is the diagnosis?
Dermatomyositis.
Well,
Or
systemic
because
lupus.
of the heliotrope rash. I see
Ah.
heliotrope rash.
No. Based on the history that we describe here,
Lupus, yeah.
systemic
Lupus.
lupus. Systemic
Lupus.
lupus is a very reasonable
Yeah.
guess, and in fact, this was the diagnosis of the rheumatologist, and there was also this alopecia, which in systemic lupus, do we expect to see alopecia?
Diffuse alopecia, but
Diffuse alopecia, diffuse
yeah,
alopecia.
maybe diffuse alopecia.
Okay.
Is-
Okay.
Is this syphilis?
Come on. Do you also know this case, or you just understood
No,
it?
no. Just the pattern on the hair.
Yeah, you destroyed the story.
I'm so sorry.
No, I didn't understand.
Okay, if you didn't understand, it's fine. In addition to the alopecia, you can also see an eruption on the trunk, erythematoscaly plaques, some kind of livedo reticularis. Look at the legs a little bit.
Yeah.
Yeah. Okay. And the palmar, on the palmar surfaces also. And then with dermoscopy on the scalp, this is what we see. So is this in line with the alopecia of systemic lupus, you think?
No,
No.
This would be in line with the alopecia of discoid lupus, maybe, but
no,
of,
they are not follicular plaques. Sebum and
yeah. Well, I'm not so sure if it's only sebum or also plugs. Anyhow,
different.
Broken.
of
broken
course,
hair.
from a clinical point of view, the first idea was that this was a diffuse alopecia areata. It was also the pattern is somehow suggestive of alopecia areata because there are a lot of yellow dots. But in addition to the dots, there are quite a lot of vessels you see around the follicles, and the broken hairs. If you look at them, they are not exclamation mark at all. So
Yeah.
Someone is writing syphilis.
someone is writing syphilis. Wait a moment. This is a photograph from one of the lesions on the trunk. You can see quite a lot of orange color with linear vessels, so granulomatous appearance overall. Therefore, trying to put all these pieces of the puzzle together in order to reach something that can explain all the findings, the cutaneous ones and the systemic ones. Here you can see the biopsy,
Wow.
granulomatous secondary syphilis, and
So the first one who said Lue was Vittorio. Vittorio,
yeah,
my resident, was saying Lue. Yeah, and then Rodolfo.
fantastic. And also look, Zoe also has a photo of the scalp 2 weeks after treatment with penicillin, of course. You see that we have a full regrowth of the hairs. So fantastic response to the treatment.
Wow.
Wow, this is
There's
one of
one more
these-
fantastic case, but we are out of time. So I
Let's show us, Emilios. They are great, really.
you want
show
more?
us.
You
No,
want
no,
more?
no,
Yeah.
we can't.
We can't.
No. But I mean, this is an exceptional case where really
They're all exceptional. Amazing cases.
this is one of these cases in which we understand why our fathers in dermatology were very good clinicians, because they had few symptoms and they were able to find the correct.
Fine. Exactly.
Wonderful.
Exactly. And also, I mean, reminding us this amazing disease, which, for a long period practically disappeared. But now I have to say that we see it again. Jeppy,
Yes.
show us.
Just shortly, I want to mention concerning the new Delta 30 Pro by Aini is that when you get one of these Delta 30, you get also this distant holder, which is very useful for many reasons. First, because you can avoid touching the lesion, so you don't alterate the vascularity, especially in the context of palpable lesions. But also, as you can see in the picture, you can use a pen or something in order to draw for example, when you excise a BCC, the correct margins of excision. So that's what I find extremely useful in my practice using Delta 30 Pro.
Absolutely. And there is also a motto for this. You remember?
Yes.
Dermoscopy. Dermoscopy.
Moss.
If you add an A. Yeah.
Come on. But today, no mottos. We had no mottos. We had no mottos.
Okay, I have still work to do. I have to present Penelope cases and the Kahoot. So you have to think about a couple of.
Let's ask our friends connected. Please suggest mottos for the episode today. Dermoscopy. Okay, this is nice.
Okay, dermoscopy
it's an advanced motto. okay, maybe a motto could be, when do you know what it is? Think about syphilis.
Yes. Okay.
Trick or trichoscopy? Tricky trichoscopy. Yeah, could be nice.
Uh-huh.
Okay, something more? Guys, please write something.
In the meanwhile, while I show Penelope's cases, friends, please help us with the motto of the day, because we cannot stop this this great collection that we are creating. So we have to find something for sure. For the smiling sweetness, dear Nisa. By the way, it's so funny because we saw just recently by Konstantinos. Okay, 65 years old, claims that this scalp lesion was always present and has not changed. Fact or fiction? This is what you get with dermoscopy. Okay, so do you see clues or not? What's your diagnosis?
Tricho,
Trichoblastoma.
trichoblastoma.
Sebaceous.
Probably again an nevus sebaceous like before,
Present for
Nevus
men.
sebaceous.
and something developing on the nevus sebaceous.
Trichoblastoma.
Trichoblastoma,
Trichoblastoma. No.
or say the second most frequent.
Syringocystoadenoma papilliferum.
Bravo.
Yeah.
Bravo. Syringocystadenoma papilliferum. That was the case. White polarized structures together with tiny vessels on a semi-translucent background. For Konstantinos, we have this spot, this small acral spot for indeterminate time. That's very important. Indeterminate time, located on the forefoot. That's the clinical. This is dermoscopy.
Melanoma.
Well, it is parallel reads, but knowing Penelope, this is most likely exogenous pigmentation.
Well, you are very close to the correct answer. It's a puzzling junctional acral nevus mimicking a melanoma, false parallel ridge pattern, crista reticulated, double-line furrow. The periphery, maybe it's visible that it's a double-line furrow pattern. For the philosopher, it's the first time she came to me for a checkup, and I've noticed this curious labial lesion that she thinks has existed for a long time. So the history says that, doctor, I have it for a long time there. Don't worry. Do you worry?
I worry for sure.
You
I
worry
worry for sure because I don't know what it is. And yeah, it could be from neoplastic to infectious to whatever. So
yeah, and there are some worrisome signs. There is this white shiny
white lines,
lines.
erythema, reticular lines,
the vessels are
reticular red lines.
Okay. What's your diagnosis? So this was a 0.8 melanoma with reticular depigmentation, shiny white lines, and atypical vessels, as we said. And finally, for me, we have this atrophic plaque. Come on, what do you think it is when you see this clinical?
Yeah.
Dermatofibroma, no?
Yeah.
Dermatofibrosarcoma protuberans, atrophic variant.
That's because you know Penelope.
Penelope, yeah.
This atrophic DFCP.
Yeah, but let's say dermatofibroma is what comes to your mind, at least to mine. But then, dermatoscopically, it's so strange. I mean, for a dermatofibroma, what are all these white clods or yellowish white clods?
This is also a dermatofibroma with sebum induction.
Dermatofibroma. So indeed, it was a dermatofibroma with this, sebum induction. Shoulder, usually atrophic, usually in females, and it's a rare unknown pathological phenomenon. And for the nicest call for the coordinator, Sebastiano, we have this 45 years old woman with a palpable, irregularly pigmented lesion, always known, located on the thigh. This is dermoscopy, and Sebastiano, make your guess. Come on, what's your
Quindi
eh?
melanoma compound nevus.
Fine.
Melanoma
Combined nevus.
combined nevus
Beautiful. Yeah.
would be also my guess. Combined nevus is a probability, but Penelope says that it's not a combined, it's a compound nevus because the blue area is not a classic blue area of a blue nevus.
Aha.
Fantastic.
Wonderful. Wonderful.
Wonderful, wonderful. Thank you so much.
Of today, bold and beautiful from Zoe.
I love it. For Emilios.
What? Sorry, I did.
Bold and
So
beautiful.
good.
Bold and beautiful.
Bold and beautiful.
Bold and beautiful.
Quote of the day for Emilios.
Nice.
Also, the folly clues. The folly clues is also nice.
What? I cannot see anything because I shared my screen. Look,
No, this is nice. Look for the folly clues.
folly clues. Nice. Folly
Yeah.
clues is nice, really nice. Okay. But I have to add them in the Kahoot. Oh my God. Okay.
Yes. Okay.
Here today,
Yeah.
gone tomorrow.
Guys,
Here today, gone tomorrow. Did you see this?
no, now I have to see everything. In the meanwhile, for 1 minute, maybe you comment something, you say something.
Absolutely. We will jabber about something. So, Zepi, do
Yes.
you love
Kostas, I love you more than ever. More and more every day. More and more every day.
We too, likewise. Will
Yes.
you be at the AAD?
No, I will not come to the American Academy. And I'm very happy.
You should be. You should be.
No, guys, this couple of episodes were longer because we wanted to speak a lot about the papers. Were very interesting, and therefore it was not so easy to make a shorter summary. But we have to try to keep the 1 hour.
That's why you start 1 minute earlier every time.
Yes. So in the meanwhile that Emilio is preparing the Kahoot, let's ask our guys, our people connected. Can you suggest for the next episode something? Just write whatever is coming to your mind. And we will
Something that you
take
like.
into consideration.
Not whatever is coming to your mind, a proposal for the next episode.
Work. Don't think about us.
Follow.
Okay. Follow up is a nice topic. Yeah. Lentigo maligna, STD.
But now I cannot copy paste anymore. Okay, good.
No, okay, don't worry.
It's okay.
Porokeratosis, inflammoscopy in general. Why not? Mucosal,
Inflammoscopy. Yeah.
Facial, nail,
Nails.
region.
Nails.
nails,
Vabbè.
bone disease.
Or
Yeah.
lesions.
Collisions.
Onychoscopy. Yeah, onychoscopy. You see how many
Inflammoscopy.
things we have to cover. Genital,
Genital.
pink,
You see,
onychoscopy.
everyone wants to know more about special sites.
Yes.
Dental, facial, nails.
Many for general dermatology. General dermatology, we have to cover more things in the general dermatology arena.
General dermatology, you think so?
Yes, I think so. The most of the suggestions are in the field of general dermatology.
Okay, let's do general dermatology on the face.
Yeah, why not?
Okay, I like it.
Why not? Good. Are you ready, Emilio?
I'm ready. So,
Wonderful.
there we go. Come on. Come on. It's a very easy Kahoot today, yeah, guys, I have to tell you.
Alrighty. Eccolo, Rudy. Good, you know.
Oh. Do you hear the sound?
Yes.
No. No sound.
No sound?
No, no,
Mhm.
it's here. It's here. It's here.
Let's hear. So, 5, 4, 3, 2, 1, and we go. Episode 8 already. Episode 8, 3,
Okay.
1. So, the poll for the quote of the day. The choices are
Trick or treat?
treat, dots, screws, and scales. Bold and beautiful. Look for the polyclues. Hair on the scalp is better than on the brush.
Then on the brush. Bold and beautiful, look for the polyclues is nice. I vote for look for the polyclues.
Yeah, it's very good, very good.
Very good.
And it is also the winner. Look for the polyclues is the winner, the winning quote of the week.
Yes.
Wonderful, fantastic. Thank you all so much. And we start our Kahoot cases with a bald scalp.
Mhm.
Go,
Why not? Why not? That's the clinical. This is dermoscopy. Okay. Everything is fine. Do you have any problems? I don't think
Perfect.
so. This is the question number 1. Which is the diagnosis? Melanoma, solar lendigo, actinic keratosis, or basal cell carcinoma? We expect a big number of correct answers because, of course, this is a melanoma and we have 125 correct answers. Among them, the fastest was Kubus, Miki, and Kankan, and Panos and Raluca, which brings us to the question number 2, which is, do you think that this melanoma is in situ or invasive? And here, please vote. And we have 103 correct answers. This was an invasive melanoma. We can say so because of this part in the left part of the lesion, which we have a complete obliteration of the hair follicles. This blotch practically is a sign of microinvasion. So it was 0.4 melanoma. Kubus remains in the first place, 433 in the second, Kankan in the third, which brings us to case number 3, again on a relatively bald scalp, a pigmented lesion. This is dermoscopy. And, okay, everything is clear, everything is visible, everything is okay.
Yes.
I think so, okay. Diagnosis.
Androgenetic
Melanoma,
alopecia.
solar lentigo, actinic keratosis, or basal cell carcinoma. And yes, the correct diagnosis found by 104 people was solar lentigo. When we see a network, it's strongly suggestive of solar lentigo. And this brings Can to the first place, followed by Evie and Tricolo in the third. Next question, again, more or less the same story. Mild androgenetic alopecia plus a few lesions, among them a more heavily pigmented one, which is this one. This is dermoscopy. And the question is again the same. Diagnosis. Do you think that this is a melanoma, solar, actinic, or basal? actinic keratosis. I'm so happy that lesions on the face became so eventually so feasible to assess. So this is a inverse approach, Kahoot. Actinic keratosis, of course. Can remains in the first place. Andreatti, MD, Franchi, and Stella. And the final one, of course, is again on the same, let's say, more or less field. So again, androgenetic alopecia, again, sun damage, again, pigmented lesions. You see here 2 of them. And the question is, this is the dermoscopy. And the question is, how many of these 2 are melanomas? 0, 1, or 2?
It was an easy Kahoot. Easy Kahoot.
That was an easy Kahoot.
Yeah.
Well, this one was not that much easy, but we have 75 correct answers. None of them is a melanoma. The one on the left is, of course, a pigmented actinic keratosis. The one on the right is, of course, a solar lentigo with reticular lines and also with parallel brown lines. And this brings us to the podium. Place number 3 goes to Stella.
Stella.
Place number 2 goes to Andreatti. And place number 1 goes to Can. Panos and 433. Fantastic. Congratulations.
Perfetto. Congratulations, Can.
Amazing.
Let's see if Can can join us.
Let's see if we have Can.
Yeah. So next episode we have to cover general dermatology. You think face? Why not rashes? Huh? Let's talk about rash. I love rashes.
Rash in general.
Yes.
May I tell you something sad?
Yes, tell me.
In the next episode, I will be on the airplane back from United States. Come on, I have to come back from United States.
Come on. No. It's not
stay there.
acceptable. It's not acceptable. Let me tell you, it's not acceptable. Yeah.
Can is here, so Can is.
Can.
Hello.
Hello.
Hi everyone.
Hello.
Hi, Can.
Congratulations.
Ava, where you come from?
Thank you. I'm from Turkey.
Wonderful.
Turkey.
What's your name? It's not Can, obviously.
Cansu. My name is Cansu.
Cansu.
Tebrikler Cansu.
Teşekkür ederim hocam. Sağ olun.
Fantastic. Where do you live in Turkey? In Ankara, in Istanbul, or somewhere else?
And now I'm in Germany, but I was in Ankara, and also I had a chance to work with dear Nisa Kayban.
Okay. Fantastic.
Thank you.
You did well. You did very well. Congratulations.
Thank you.
Wonderful. Okay, guys, have a nice sleep or have a nice day, and see you next Sunday.
Thank you all so much.
Thank you, everyone.
Bye bye.
Baci.
Bye, everybody. Bye-bye.
Bye.